for this nice invitation. And my talks will be about the types of bridge in BEVAR and FEVAR. We can start our slides. There is no conclusion that we know that the endovascular aneurysm repair is well established and more effective alternative to open repair. In spite of that, the EVAR still have some limitation for like adequate infrarenal neck lengths and angulation. But with innovation of the field, EVAR has led to development of more complex endografts, and that's include fenestration, branching, chimney, which increase the anatomical spectrum of abdominal aortic aneurysm repair, and that be effectively treated using this endovascular graft. So the fenestrated endovascular aneurysm repair was first performed in 1996, and after 2 years of that, they start the fenestrated graft. And it is managed mainly for the major branch of the aortic arch, visceral aorta, posed to particular challenge for endovascular repair, and that to preserve the perfusion through this essential branches or fenestration for that target vessels. In general, this is the old classification of Crawford classification. It was established in 1986, and 1999 was modified by Safi. For complex abdominal aortic aneurysm, that's either infrarenal or juxtarenal, pararenal, or type 4 thoracoabdominal, what's called suprarenal. And open management for each type, either tube graft standard infrarenal or fish mouth to preserve the orifice of the renal artery, or implantation of the renals or interposition graft and extend the graft to the suprarenal or patch graft of the SMA and celiac artery. Same issue is in endovascular. We use either standard EVAR infrarenal or chimney, or we can use fenestrated or branched graft for suprarenal arteries. Open surgery and endovascular need facility, and it's a major surgery for the open surgery, and of course it's not minimal surgery, but we can say minimal access surgery for endovascular, and you need technology to help you for the endovascular repair. The mortality rate in the open surgery is still high. It's reached in elective repair to 6%, and for symptomatic patient to 15%. We can use either bridged stent graft in direct inner cuff or reinforced fenestration. In general, there is no dedicated device for use as a bridging stent, and a variety of stent grafts are currently used off-label. When we plan patient for endovascular surgery for fenestration or branched graft, we have to plan the surgery properly, looking for the landing zone proximal and distals, the lumen of the aorta, and the sac dilatation, distance between the vessel, and angulation of each target vessels. Good planning, you have a good result. If you know, you will get the catastrophic results. So selection of appropriate bridging stents play a critical role and on the durability of the repair. And the aim of the fenestration and branched graft just to achieve the appropriate proximal zone. This is the type, either directed branches or fenestration. And you can use self-expandable or balloon expandable or even per stent. This is the types we use it on shelf. Either scallop or fenestrated, reinforced, or directed branch graft. So many types of covered stent can be used, either balloon expandable or self-expandable. We know it either V12, B graft, even VBX, live stream for the balloon expandable, and self-expandable, we can use Fluency, Viapan, or Covera. Each type have its own advantage and disadvantage. Each type, I mentioned this one. So the advantage of self-expandable stent with their flexibility and comfortability. Because of that, self-expandable have been preferred for directional branches. And this show also the VBX have its criteria for flexibility and can be used safely in tortuous vessels. Again, the fenestrated graft can be used balloon expandable, and we have the flare, the proximal at the fenestration site to guarantee the sealing. So in general, where is the vessel is tortuous and where morphology involves proximal stenosis and luminal irregularity related to atherosclerosis disease, self-expandable are likely to be performed better than balloon expandable. An important drawback for the self-expandable stent is less precise deployment and poor trackability. Most of the experts agree that directional branch should be used for downward vessels that originate from large aortic lumen with a steeper takeoff angle, and when there is a larger gap between the to be bridged. And the fenestration should be used for vessels that originate from the sealing zone with close 90-degree takeoff from the aorta, and when the main aortic body at the level of the target vessel is adjacent to the aortic wall. We can use the peristent for extending of the distal sealing or treating endoleaks or prevent distal outflow obstruction. This is the types of the target branch can be horizontal, upward, or downward, or can be tortuous. And that's what we deal it usually with self-expandable is a good tractability and can be deployed properly in the tortuous vessel. Can move it, please? Okay, sorry. In general, the patency is comparable between the balloon expandable and self-expandable. It reached to 96% in 1 year, 98% in 1 year, and 96% in 5 years. Can you move it, please? So just the key points when you are planning for fenestration and branched graft. This is for the axis as a standard AVAR. You can plan it for the axis. And for the visceral segment of the abdominal aorta should be the diameter not less than 20 millimeters, and the aortic diameter inferior not less than 18 millimeter. In general, looking at you have to consider the atherosclerosis and thrombus in the wall of the aorta, and the distance between each visceral artery not less than 5 millimeters. For the side branch target, you have to look for the angulation and diameter of each visceral not less than 4 millimeters, and you have to consider the accessory vessels originating at the hypogastric. And the endoleak, for the types of endoleak in branched and fenestrated graft is standard endoleak in standard EVAR, but we add type 1C, which is side branch attachment, and type 3B, either break or in the graft wall, and type 3C, when there is also disattachment of the graft from the aortic stent. In conclusion, the fenestrated and branched endograft have greatly expanded vascular surgeons' armamentarium for the management of complex aortic disease, and the bridging stents that connect the aortic main component to the target vessel is key component of BEVAR and FEVAR. Yet there is no agreement as to ideal bridging stent for target branch. This lack of consensus has led to vascular surgeon using wide combination of self-expandable or balloon expandable covered stent. Thank you.